Today we'll talk about the rectum and the anal canal. At the end of the lecture, the students should be able to discuss the features, situation, extent, dimensions, course, relations, curves, mucus folds, blood supply, nerve supply, and clinical aspects of the rectum. Also, discussion of the length, extent, direction, relations, the interior three parts, blood supply, nerve supply, and the clinical aspects of the anal canal. Now, the lowest part of the gastrointestinal tract is formed by the rectum and the anal canal. Now, the useful components of the food are absorbed and the waste material expelled out from the anus, which is the external opening of the anal canal seen in the perineum. Now, the anal canal is heavily guarded by the sphincters and it is subject to many diseases. Basically, it is the balanced food and proper timing that decreases the incidence of these maladies. Firstly, we see the rectum. Okay, it is the distal large part of the large intestine placed between the sigmoid colon over here and the anal canal below. Now, distension of the rectum causes the desire to defecate, and the rectum in man is not straight, whereas the rectum, the word itself means straight, but straight is in lower animals, not man. In fact, it is curved anterior posteriorly and also from side to side. The three cardinal features of the large intestine, that is the saculations, the tinea coli, and the appendices epiploe, are absent in the rectum. Basically, the rectum is situated in the posterior part of the lesser pelvis, in front of the lower three pieces of the sacrum, 1, 2, 3, and the coccyx. It is extending from the sigmoid colon, basically beginning as a continuation of the sigmoid colon. This is the sigmoid colon at the level of the third sacral vertebra. Okay. The rectosigmoid junction over here is indicated by the lower end of the sigmoid mesocolon. The rectum ends by becoming continuous with the anal canal at the anorectal junction. Now, this junction is lying about 2 to 3 centimeter in front and a little below the tip of the coccyx. In males, this junction corresponds to the apex of the prostate gland. Now, the rectum is about 12 centimeter long. In the upper part, it has the same diameter as that of the sigmoid colon, and the lower part dilates to form the rectal ampulla. Now, in its course, the rectum first is running downwards, backwards, downwards, then backwards, and finally forwards like this. The beginning and the end of the rectum are lying in the median plane, but it is showing two types of curvatures during its course. There are the two anterior posterior curvatures. We have the sacral flexure over here that is following the concavity of the sacrum and the coccyx. Then we have a perineal flexure of the rectum that is at the backward bend of the anorectal junction. Now, you can see the lateral curves of the rectum. The upper lateral curve is convex to the right, this major one. The middle lateral curve is convex to the left and most prominent, and then the lower lateral curve is convex to the right. Okay, so this is the most prominent middle lateral curve which has the convexity to the left side. This is the upper and the lower lateral curve which are showing convexity on the right side. Now coming to the relations. Firstly, let's talk about its peritoneal relations. Number one, the upper third of the rectum, this part, upper third of the rectum is covered by the peritoneum, as you can see, only in front. It is in front and on the sides. The middle part is covered by the peritoneum only in front, this one, this middle part over here. Whereas the lower one third is dilated to form the ampulla and is devoid of peritoneum. Lying below the rectovesical pouch, okay, in males between the rectum and the bladder, this is the rectovesical pouch, and in females, the rectouterine pouch. The distance between the anus and the floor of the pouch is about 7.5 centimeter in males and only 5.5 centimeter in female. This is important while performing a PR examination, a per rectal examination, okay, in case of any accumulation of fluid or any prolapsed ovaries found over here in the rectouterine pouch in females. Here you can see these are the relations, the rectouterine pouch over here. Okay. Now coming to the visceral relation, previously we read the peritoneal relations. Amongst the visceral relations, anteriorly in males, the upper two thirds of the rectum is related to the rectovesical pouch and coils of intestine and the sigmoid colon. The lower one third of the rectum is related to the base of the bladder, the terminal part of the ureters, the seminal vesicle, the ductus deferens, and then the prostate gland. Anteriorly in females, the upper two third of the rectum is related to the rectouterine pouch of Douglas and the coils of the intestine and the sigmoid colon, whereas this pouch is separating the rectum from the uterus and also the upper part of vagina, some part of the upper part of vagina as well. Lower one third of the rectum is related to the lower part of the vagina. Now posteriorly, these relations with the posterior relations are same in the male and the female, that is the lower three pieces of the sacrum and the coccyx, and here this is the anococcygeal ligament over here, the piriformis muscle, the coccygeus and the levator ani. Okay. Also we have the median sacral artery, superior rectal and the lower lateral sacral vessels, the sympathetic chain with ganglion empire, the anterior primary rami of S3, 4, 5, coccygeal 1 and the pelvic splanchnic nerves, along with lymph node, lymphatics and fat. Very important are the mucosal folds found inside the rectum. This is the interior of the rectum. You can see that the mucous membrane of an empty rectum showing two type of folds. Okay, we have the longitudinal folds and then we have the transverse folds. The longitudinal folds are transitory. They are present in the lower part of the empty rectum and they get obliterated by distension. Whereas the transverse folds over here, are also called the Houston's valves or plicae transversalis. These are permanent and most marked when the rectum is distended. So now coming to the first transverse fold, lies at near the upper end of the rectum, projecting from the left wall, situated 7.5 centimeter from the anus. Sometimes it may encircle and could be partially constricted, constricting the lumen. The second transverse fold is the largest, most constant, lies at the upper end of the rectal ampulla and projecting from the anterior and the right wall. The third transverse fold, which is inconsistent, is lying 2.5 centimeter below the third fold and projecting from the left wall. Functionally, the sigmoid colon is a fecal reservoir and the whole of the rectum is empty in normal individuals, being sensitive to basically distension. And the passage of feces into the rectum will cause the desire to defecate. Now, very important is the arterial supply of the rectum. Firstly, we have the superior rectal artery, which is the chief artery of the rectum, continuation of the inferior mesenteric artery at the pelvic brim, medial to the left ureter. It is lying in the medial limb of the pelvic mesocolon and it is dividing opposite the third sacral vertebrae into a left and a right branch which run on the sides of the rectum. Now you can see this is the right branch, the left branch. Now each branch is breaking at the middle of the rectum into smaller branches, piercing the muscular coat and running up to the anal columns and the anal valves where they are forming looped anastomoses. What are anal columns and anal valves, which we'll do further on. Okay, they are, so you can see they are going up to the anal canal. Okay. Second, we have the middle rectal artery. Supply only the superficial coat of the lower part of the rectum. They are arising from the anterior division of the internal iliac artery running in the lateral ligament of the rectum, supply the muscle coat of the lower part of the rectum. Their anastomosis with the adjacent arteries are very poor compared to the loop anastomosis of the superior rectal artery. This is the median sacral artery over here, which is a branch arising from the back of the aorta near the lower end, descending in the median plane and supplying the posterior wall of the anorectal junction. Coming to the venous drainage of the rectum, we have the superior rectal vein beginning at the anal canal from the internal rectal plexus in the form of about 3 veins of considerable size draining into inferior mesenteric vein. Now, they pass upwards in the rectal submucosa, piercing the muscular coat about 7.5 centimeter above the anus and unite with the superior rectal vein, which continues upwards as the inferior mesenteric vein and ends up in the splenic vein. We have the middle rectal vein as well. Tributaries of this vein are draining chiefly the muscular walls of the rectal ampulla and opening into the internal iliac veins. Then we also have the median sacral vein that joins the left common iliac vein. Now, coming to the lymphatic drainage, lymphatics from more than upper half of the rectum pass along the superior rectal vessels, as you can see here, to the inferior mesenteric nodes. After passing through the pararectal and the sigmoid nodes. Now, lymphatics from the lower half of the rectum pass along the middle rectal vessels into the internal iliac nodes. Lymphatics from the lower part of the anal canal drain into the superficial inguinal lymph nodes. Nerve supply. The rectum is supplied by both. This is the rectum. This has been cut over here by both the sympathetic L1, L2 and the parasympathetic S2, 3, 4 nerves through the superior rectal or inferior mesenteric and inferior hypogastric plexus. This is the inferior hypogastric plexus. The sympathetic nerves basically are vasoconstrictors, inhibitory to the rectal musculature, and motor to the internal anal sphincter. Now, the parasympathetic nerves, okay, are motor to the musculature of the rectum and inhibitory to the internal sphincters. Sensation of distension of the rectum passes through the parasympathetic nerves or the pelvic splanchnic nerves, while the pain sensations are carried by both sympathetic and the parasympathetic. Coming to the supports of the rectum, this is the rectum. Okay, you all know about the levator ani. So pelvic floor formed by the levator ani is forming one of the supports of the rectum. Coming now to fascia of Walder, very important. Okay, this fascia, the rectosacral fascia, fascia of Walder, attaches. This is the fascia attaching to the lower part of the rectal ampulla to the sacrum here. Okay, formed by the condensation of the pelvic fascia behind the sacrum, and this is enclosing the superior rectal vessels and the lymphatics. Coming to the lateral ligaments of the rectum, this is the rectum. They are formed by the condensation of the pelvic fascia on either side of the rectum, enclosing the middle rectal vessels. The branches from the pelvic plexus attaching the rectum to the posterolateral walls of the lesser pelvis. Another important is the rectovesical fascia of Denon-Willards over here, rectovesical behind the bladder. This is the bladder, prostate, seminal vesicle. Okay. It is extending from the rectum behind to the seminal vesicle over here and the prostate in front. The pelvic peritoneum and the related vascular pedicles are also keeping the rectum in position. And the last but not the least, we have the perineal body also giving support to the rectum. Now, coming to the clinical anatomy, very important. You have all read previously about the digital rectal examination, in which the finger is entered within the anal canal before reaching the lower end of the rectum. Now, in the normal person, the following structures can be palpated during a rectal examination. In the male, we have the posterior surface of the prostate, the vas deferens, and the seminal vesicle. In females, anteriorly to a rectal examination, we can palpate the perineal body, the cervix, the presenting part of the fetus during delivery, and in both the sexes, the anorectal ring, the coccyx and the sacrum, and the ischioanal fossa along with the ischial spines. Now, in patients, that was in the normal person. In the patients, a rectal examination can be helpful for the following abnormalities. Within the lumen, we can have within the lumen of the rectum, we can palpate for fecal impaction, foreign body, bleeding piles or hemorrhoids. Within the rectal wall, some any rectal growth or strictures or thrombosed piles can be felt. Now, outside the rectal wall, in the males, enlargement of the prostate, seminal vesicle, bulbourethral glands, and stone in membranous urethra. In the females, enlargement of uterus, tubes, ovaries, abnormalities in the pouch of Douglas, and in both the distension of the bladder, low ureteric stones, tumors of the bony pelvis. Okay. Also, in a per-rectal examination after during parturition, dilatation can be commonly assessed through the rectal wall. To avoid infection by repeated vaginal examination, you can see this is the rectum, this is the bladder, okay, and we can palpate the cervix over here. This is the enlarged uterus containing the fetus. Now, what is proctoscopy and sigmoidoscopy? The interior of the rectum and the anal canal can be examined under direct vision. Okay, and these instruments used are the proctoscope or the sigmoidoscope. You can see the picture. Sigmoidoscopy, it is helpful in revealing any ulcer, growth, or diverticula, or in taking a rectal biopsy. This is a proctoscope. Okay, show the internal piles and growth in the lower part of the rectum, right? So, what is prolapse of the rectum? It's a normal rectum. This is the prolapsed rectum. Incomplete or mucosal prolapse of the rectum through the anus following a violent straining or due to imperfect support of the rectal mucosa by the submucosa. That can also lead on to the prolapsed rectum. Also, this procedentia is a condition where there is complete rectal prolapse in which the whole thickness of the rectal wall is protruding through the anus. It could be caused by the laxity of the pelvic floor due to the laxity of the pelvic floor, excessively deep rectovesical or the rectouterine pouch, or inadequate fixation of the rectum to its pre-sacral bed. Now, the neurological disturbances of the rectum. Now, in spite of having identical innervation of the rectum and the bladder, the involvement of the rectum in nervous lesions is less severe compared to the bladder. After sacral denervation of the rectum, the peripheral nervous system is controlling the automatic evacuation of the rectum. You can see this is the inferior hypogastric plexus, the pelvic sphinctic nerves. Now, this reflex activity is more massive and complete when sacral innervation is intact. That is, complete cord lesions above the sacral lesion. Okay. In commonly, we have the carcinoma of the rectum or the colorectal carcinoma, generally situated at the rectosigmoid junction, which is constricting type, or in the ampulla, which is proliferating type, causing bleeding per rectum from an indurated raised ulcer. This condition is surgically treated by abdominoperineal excision, in which the anus, the anal canal, and the rectum with the facial sheaths, and a varying amount of the distal colon, this is the colon, along with the mesocolon containing the lymph nodes are removed and blocked, and a permanent colostomy in the left iliac fossa is done with the proximal cut end of the colon. Coming to the rectal incontinence, depends solely on the anorectal ring, okay, and damage to this anorectal ring results in rectal incontinence, and the surgeon therefore has to carefully protect this ring in order to operate on this region. So that's about the rectum. Next we shall cover the anal canal.